Let's talk about aortic regurgitation. So first of all, what is it? Well, you need to be familiar with the term regurgitation, right? So regurgitation, when we're referring to heart valves, is referring to a valve that is supposed to be closed, shut, but it's not. It's been insulted for whatever reason, and it's not able to shut tight and seal off that valve when it's supposed to. So regurgitation, think regurgitate the volume. Okay, we're regurgitating volume back up into where it's not supposed to be. In this case, it's regurgitating from the aorta back up into the left ventricle. So, what are our underlying etiologies or causes? Worldwide, the most common is rheumatic heart disease, which is caused by rheumatic fever, which is caused by strep. Another infective cause could be infective endocarditis, Marfan syndrome, which we know is a connective tissue disorder. Other connective tissue disorders like lupus can lead to aortic regurg. And then finally, long-standing, poorly controlled hypertension, which is probably the most common underlying etiology here in the United States. But worldwide, again, it's rheumatic heart disease. So what is the patho? So there's that word again of incompetent. The aortic valve has become incompetent because of an insult of some reason. And it does not close like it's supposed to during diastole, okay? Remember, the aortic valve is supposed to be closed during diastole. And so when this happens, when it doesn't close when it's supposed to, it's going to allow blood to backflow up or regurgitate back up from the aorta back into the left ventricle during diastole. This causes an increase in left ventricular end diastolic pressure. It increases pressure in the pulmonary vasculature because always remember, if blood is not being moved forward, where is it backing up into? And we know that blood is returned from the lungs into the left side of the heart. So if it's not moving forward, blood is going to back up into the lungs. And so eventually that leads to left ventricular hypertrophy, which we know is enlargement, thickening of the ventricular walls, and then heart failure as aortic regurg progresses. So what are our clinical manifestations? Now, I always like to say there's going to be no clinical manifestations or very unnoticeable clinical manifestations when aortic regurg is very mild, okay? This is not what we're talking about. We're talking about moderate to very severe aortic regurg when we're talking about these clinical manifestations. So first of all, a diastolic murmur. Why are we going to hear a diastolic murmur? Well, remember, the murmur is going to be produced when this heart valve is supposed to be closed, but it flaps back open and allows for regurg of blood. The aortic valve is supposed to be closed during diastole, and it's not. So we're going to have a diastolic murmur with aortic regurgitation. We're going to see a widened pulse pressure. In other words, a very, very high systolic blood pressure and a low diastolic. So this happens because of those regurgitant volumes that are allowed to backflow back up into the left side of the heart increase systolic pressure because now you've got all this extra volume, all this extra stroke volume that the heart has to push out during systole. But the incompetent aortic valve allows for pressures within the aorta to decrease during diastole. So the widened pulse pressure, you're going to see a very high systolic and a very low diastolic. You're going to feel a water hammer pulse. I skipped over tachycardia, but yes, tachycardia is one of those compensatory mechanisms for decreased cardiac output. The water hammer pulse. So what is this? This is a pulse that you're going to feel in the patient's arm, in the upper extremity. It's best felt if you ask the patient to hold their arm up, and you can feel radial or brachial pulse. And what happens is it's a very, very bounding pulse that you'll feel. And what causes it is that very rapid return of blood flow back to the heart during diastole, is that aortic valve is wide open and allowing blood to flow back up into the heart during diastole. So that's why raising the patient's arm up when you're assessing for this will make that water hammer pulse even easier to feel, and it's very distinguishable. And again, only going to be felt with very severe or acute aortic regurg. Demusit sign, okay, so this is, and forgive me if I'm pronouncing that wrong, this is going to be a bobbing of the head with every heartbeat that we see in very severe aortic regurgitation. And it just has to do with those high volumes, those regurgitant volumes, causing increased pressure within the carotid arteries and, things like that during every heartbeat. So you'll see that bobbing head. You'll see something called hill sign. So a hill sign is a very, very pronounced difference in blood pressure down in the lower extremities, most significantly in the popliteal pulse. So blood pressure in the popliteal pulse will be very, very much higher than blood pressure within the brachial pulse. More specifically, systolic blood pressure. Systolic popliteal blood pressure will be way higher. I think they define it as 60 millimeters of mercury higher than blood pressure in the brachial pulse. And this has to do with that the arteries down in the lower extremities are a direct extension of the aorta. And so that increased volume is going to lead to a very, very high systolic blood pressure down in the lower extremities as compared to systolic blood pressure in the upper extremities. So chest pain, angina, again with severe or acute aortic regurg. Dyspnea on exertion. This is probably going to be one of the earlier signs that the patient starts to notice. An S3 will be heard once the patient progresses so far that they're now experiencing heart failure, and a displaced apex because of volume overload. So S3 and that displaced apex, when you're listening to the heart, are both due to volume overload in severe or very acute aortic regurgitation. So nursing care, what are we going to assess? Obviously, we're going to assess heart sounds, right? And they're best going to be heard with the patient sitting up and at end expiration, because that gets that apex closest to the chest wall, and you'll be able to hear that diastolic murmur much better. We're going to listen to heart rhythm. We're going to take heart rate and blood pressure, obviously breath sounds, oxygenation, mental status. What are we going to do as far as nursing care? Well, especially if a patient is in like a decompensated state, if it's acute, if it's severe, we're always going to position them upright and give them oxygen, right? Antibiotics are going to be a mainstay if it is caused by an infectious process. We're going to do positive inotropes, which is like your medications like dobutamine, which is going to help increase cardiac output and increase that squeeze. Vasodilators are going to decrease afterload or decrease the work that the heart has to overcome to pump out to the body. Cardiac glycosides like digoxin are going to help control heart rate. And then blood pressures, ACE inhibitors, not during acute aortic regurg, okay? Only chronic aortic regurg to help manage blood pressure. And then obviously antidysrhythmics if atrial fibrillation or other palpitations are an issue. So I hope this video has helped. Happy studying, and as always, go Vols.